everybody. Welcome back to session 5. Good to have folks back. We're coming down to the wire here. Session 5 is going to be a very, very important topic, challenging for some of you, others not so much. So just reminding folks that it's a learning collaborative. So some people may be at different points on their journey, and we all come from different settings, and we benefit from hearing about experiences in other settings. What we're going to be talking about today, we're focusing on the technology and the analytics. Before I go through objectives, why don't we do a roll call? I'll start first with the Optum team. I'm Carol Dahl, and I've introduced myself before. You guys know me. I'm with Optum. Sherry, you want to go?
Sure, Sherry, I'll be with Optum. I've been with Optum for 5 years. Also have been on these calls for the last 3 months, I think we're going on.
And Natalie's joined us today. Natalie, are you there?
I am. Hi. Nice to see people again virtually.
Okay. Why don't we do participants next, and then we'd move to ASU. If you could tell folks your name and just again reminder what your what the name of your org and what type of org it is.
This is Susie Boucher. I'm with AltaPoint Health Systems. We are a behavioral health provider in South Alabama. And unfortunately, I'm the only person from my team today. My partner, who is in our IT department, is actually on the road today, so he can't be joining us. I'm kind of bummed about that.
Susie, we've gotten to know you over the last 4 weeks. I think you're a collaborative partner. My guess is you'll share the information with your partner.
I will, certainly.
I know. Good to have you back, Susie. Who's next?
Thanks.
Hi, this is Renee Bulk. I work for a large community mental health or behavioral health provider in Portland, Oregon.
This is Tracy Smith, Southern Illinois University School of Medicine in Springfield, Illinois, and I'm with the FQHC. And I have a student listening in with me today.
Dennis?
I'm Dennis Lewis. I'm the executive director of a dental health provider in Boulder County, Colorado. We see about, 9,000 patients a year, about 27 to 28,000 visits a year.
No small task. Thanks, Dennis, for being on today. Is there any other participants out there that I missed? Okay, AJ, you want to introduce your team?
Yeah, sure. Yeah, sure. I'm AJ. I'm here from the ASU team. I'm sure I've been in email correspondence with a lot of you, so just be sure to reach out to me if you guys have any questions. So that's all I pretty much have from our end, so take it away.
And Peter's on with us, always supporting technology from afar. Okay, so again, our objectives for today, will be going over the homework in a little bit, but we're going to review the various trends that are out there today with HIT, or Health Information Technology. And we're going to talk about, does it support your value-based contracting? Does it support, does it lead, or do you have the flexibility to make it work for you? We've talked about understanding roles. We'll be talking about understanding the roles. Throughout our presentations, we focused on teamwork and the importance of the interdisciplinary approach, but how important HIT is in your team for the clinical management. And what capabilities do you need to make sure that your HIT is successful to implement your value-based contract? With that, let's move into the homework. When you look at where we started and where we're at, we reviewed a value-based contract. And again, just reminding, some folks are in the thick of things with value-based contracts. Others are being presented with opportunities. Others, they're just like knocking on the door to get some value-based contracting going, but nothing is happening. People aren't getting it, but they're thinking ahead. They see the importance and they know it's coming. So either you've got a value-based contract, or one is in your backyard and coming, or you're way ahead of the curve and you're thinking, how could you propose maybe a value-based contract, given that in earlier sessions you identified your cohort. We've heard from some folks who pick diabetics. Some folks have talked about their population was provided to them, looking at folks with hospitalizations or 3 ERs, but what's that cohort you're looking at? And the session before, we looked at what were the program interventions you were going to implement for that cohort. And our last session was, given all those things, what are 5 workflows or processes that will need to change in your organization as a result of this? So either something you're going to have to add, you've never done HRAs before, or you're going to have to modify the process. It works, but you haven't been collecting the data, so maybe you need to build in some data points, or it's totally out of whack. You've got to re-engineer the whole thing, or, gee, we've done it this way forever. It's double work. Why are patients documenting their demographic information 16 times? Let's get rid of it. So let's have 2 folks go today in the interest of time. Tracy, I don't want to pick on you, but I don't think we've heard from you for a while, or Renee, or either you folks be willing to talk up about what sort of workflows or processes that you're going to need to change.
So this is Tracy, and I'm glad to talk about mine. And I hope this is the direction that you were interested in. But for me, I wanted to create a what we found with our super utilizers of the emergency department is that our clinic flow does not positive results to keep them out of the emergency department. So we decided we wanted to create a new clinic setup in our clinic called our Complete Care Clinic. And as we started to talk about that, we found issues around we have to address how those patients will be scheduled and how they'll be identified in the special group that should come to that special clinic. And so what we've had to do is go back into our scheduling mechanism and look at a new way to schedule and give me access to schedule, since they'll be hand-picked patients, and then developing a banner that goes into our EHR to identify those patients, that they're part of this special program. And so we've had to work with IT to look at how to do those pieces. We also had to look at the scheduling template because we wanted to individualize the amount of time set up for a patient based upon what we knew their need was. So we only had 2 choices. We had new patients or we had established patient minutes. So we went from, we have a 20-minute new patient visit to a 10-minute established patient visit. And we didn't want to be confined to that type of a scheduling mechanism. So we had to re-look at how do we change the scheduling to give us more flexibility in that so that we can match our productivity needs also. And then we had to go back and look at our task list and how would the tasks associated with that patient care, how would they go to the nurse or the care coordinator or the other new partners involved in this, and develop that that algorithm of a flow of questions that came in and were taken and who would answer those and how those would be addressed. So that's just some of the pieces that we've had to look at to develop this new clinic, because then when we do that, then it's a trackable mechanism and we can monitor the outcomes better for these clients.
Wow, so you've had to add a process, you've had to modify a process. You've done a lot of different things. So you're starting with who you're trying to keep out of the ER, and we're identifying them. You've created a whole new, what did you call it, Complete Care Clinic?
Yes, Complete Care Clinic.
Wow, and then you had, so as a result of that, you had to look at scheduling, how you're going to identify, scheduling templates, adjusting appointment times, task list, triaging. That's a lot.
Yes, and we had to our provider our provider buy-in, who's our backup provider, and it's not just a physician clinic. It's a physician, community health worker, social worker, and a pharmacy that will man that clinic. And do all patients need to be seen by the physician, or how do we select who needs to see who? And the billing process under that, because my pharmacist has a way of billing, my community health worker has a way of billing, my social worker has a way of billing, and my physician has a level of billing. And so then we put a tracking mechanism in place to look at our reimbursement for each one of those visits in a different format, because we should have improved billing for the care of that patient.
How did you determine who was going to be in the clinic? You know, so you've got a social worker, you've got a physician, how come you didn't need to put a podiatrist there or a dentist, whatever? What made you constitute the team the way you did?
Part of it is the resources that we have available to us. Secondly, it is, as we've done a lot of pilot studies in the community, these were some of the folks we saw that needed to be of easier access to individuals to help them access those other specialists that you were talking about. So this is kind of the frontline access piece, and they help then to lead back to the specialization access component piece. We don't have dentists available to us in an easy format to move into our clinic setting, but we do have a good movement out of our clinic into our dentist. So those connections are all made, but these were the front line that had to be there so we could emphasize those connections so they easily came into place.
Okay.
Did you have discussions? Yeah, I'm thinking of, it's great that you have an opportunity to sort of pilot a little bit and then structure in essence a new entity or a new clinic or new concept, where we've tried to get more uniformity in terms of care team structure and the other types of changes you've talked about for patients with particular high risks, like those suspected of opioid abuse, for example. We've had a lot of intense debate between providers about, what they're willing and not willing to do with regard to being that anchor part of the team. Did you have similar conversations when you were selecting the team or trying to figure out the right team to do this?
Yes. So we have had, again, a pilot program of hotspotting, and I have two physicians who have stepped up as really those leaders to be able to deal well with my patient super utilizers so that they're comfortable practicing a harm reduction model and some of those other models that other providers aren't always comfortable with and that may have that decision, discussions. And so they've really been involved in a very small scale. We've taken 5 for 2 years now and did this, and they've seen the improvements and decreased burnout they had in caring for those patients, and so now they're all in to have a larger clinic population that we have set about 60 to manage this way.
Any other questions or comments from the group?
Yeah, this is Susie. Tracy, this sounds really great. One of my questions is, so what are you using to determine who's a super utilizer? What's the criteria? How many visits and what amount of time?
So since some of our funding has came from our hospitals, we use a lot of ED super utilizer data measurements, and so it's really if they have more than 6 ED visits in 6 months or more than 3 inpatient visits in 6 months. And we originally went within a year, but we found so many that we went down to 6 months, and that criteria has helped us to find the largest with folks. So those are our 2 pivotal points. And then once we started that, we started to get some providers who said, well, this patient has a huge potential to be a super utilizer. Can we address potential super utilizers? So that's the next thing we're looking at, because that's even a little bit different of an encounter. components health-wise. So that's
exciting, trying to be proactive and to predict going to be the utilizers before they even come through and being reactive to the use. Terrific.
we have gratification that we're piloting to see how it does in prediction.
Good. I think we could spend a lot more time, but in the interest of time, I'm going to move us along. Thank you so much, Tracy. Very exciting stuff. Renee, are you willing to share anything today?
Sure. Yeah, of course. So the timing is interesting as we talk about, workflows and pathways and all that good stuff. I feel like I'm thinking about it so much that I'm dreaming about it often. So Oregon was awarded the planning grant for CCBHC, and we're pursuing this designation for 3 of our outpatient clinics. So we're doing a lot of work around thinking about, team-based care, identifying team roles and what the workflow looks like. So I certainly don't have any answers or a completed product today, but as we're thinking about a potential different funding stream, we're also thinking about how to best utilize the roles and the skills and the knowledge of our staff. So we've been doing a lot of thinking around where roles such as care coordination might best fit, if it's not like a dedicated staff person, if, every clinician or staff has a piece of care coordination as part of their job, or perhaps it depends upon maybe the acuity or the caseload of a client or of a staff on how much care coordination they do. So, we don't. Like I said, I don't have an answer today. But as we're going through the certification process to become a certified community behavioral health care clinic, we're considering all of the things that we need to do to meet the designation and how to best fill the role. And I think right now that we're thinking that given the large number of individuals we serve that are on the higher acuity side of things and would really benefit from additional care coordination, we're looking at having a dedicated role for that as we see that we need to support people in accessing primary care and in engaging in health and wellness services. That's not something that we feel that our clinicians are best geared to do or maybe perhaps don't have all the time required to do. So we're working through the workflow process, but we certainly don't have any answers right now. But we expect to over the next few months around what our process will look like.
I think it's courageous to admit you don't have all the answers. The times they are changing, and staying flexible given the situation that you're in. It worries me, though, that you're dreaming about all this, Renee. You need to get your...
Oh, well, I like to think that I'm being productive even in my sleeping hours. But, I think, right now, and I'm not sure about the rest of the country, but, at least locally, we have such an opportunity. And, it's really exciting, but it's also a lot of work. And my concerns aren't really around, building the infrastructure or the workflows. I think, my biggest concern is just making sure that we do things in a timely way, and we're very intentional about how we shift the culture, because, setting up the infrastructure is easy enough, and having the clients, I think, is often buy-in is easy enough, but we need to do the work to shift the culture of the staff to make them realize how diabetes, for example, even though they're an outpatient therapist, they do need to think about diabetes and not treating diabetes, but how diabetes impacts their clients with depression or how they can support their clients in managing their diabetes through, non-medical means. So lots of things going on, which is exciting, a little crazy making, and I'm just appreciative of the opportunity that we have through the Learning Collaborative to kind of talk things through and hear from, other states and organizations and things like that.
Well, shifting culture is major, and your governance, your leaders are supportive in the efforts. You keep them informed and...
Yeah, absolutely. I think this is the direction that the agency is going in, and integration of primary care and health and wellness services is part of our strategic plan. So we have, everyone on the executive and senior leadership teams, buys into this, and this is what, the direction that our agency is going in. And I think, a number of people feel like this is probably the direction that a lot of community behavioral health providers will be going in what we're doing is not working as well as we would like it to, I think, as a system. We serve a lot of people, and that's great, but I think that we can do that better by taking a more holistic approach and helping people to access care and providing like the health promotion and prevention services at the community behavioral health provider, because people at least our clients aren't necessarily accessing that through their primary care provider or in the community. So, as an agency, we believe that this is what we need to do to best support our clients and how we're going to actually move the dial on achieving better health outcomes and affecting healthcare transformation.
So we found that, yeah, actually, thank you for sharing, Renee. And we've found, Carol, you're right. Culture change is a big deal. And it's not just the recognition of, okay, we're trying to do something different. Therefore, our view of the world and how we're trying to work with people, including our patients, is quite different. Tremendous communication challenges, getting leadership on the board and having it cascade through the organization. We found that's like a 2 to 3 year journey just to get the basics instilled. Like, yeah, hey, we're doing this. And then the other thing is, go ahead.
Well, and just to kind of, with your comment, I think it's 2 to 3 years, at best, because I think what we're seeing, and I'm sure a lot of other people are experiencing, is high turnover rates, right? So we do a lot of work, and I think we have like a really good year. We've done some significant change around changing the culture, and then we have another wave of turnover and starting that over again. So I think one of the things that I struggle with is, how can we create this culture in a way that's sustainable, that 1 or 2 or 3 key people aren't pushing it, but it's now the culture of the agency and everyone's kind of pushing that this is our philosophy and this is how we work. Because I think culture change is always the most challenging part.
One of the nice things about turnover is that you have the opportunity to then try to think about the skill sets you really need. And, but one example of that is, I think we had a discussion about, so we're asking our nurses and other people involved in care management processes to do things differently. A nurse in clinical practice administering services is not necessarily the same skill set and temperament as a nurse who might be doing case management, for example. So, how can you use the hiring opportunity to help shift culture?
I agree 100%. And I think one of the things that I kind of speak about a lot because it frustrates me is, it's frustrating for me when we have clinicians that are just coming out of school, are super excited and eager to be practicing, and they aren't really prepared for what community mental health looks like. So not only are they not prepared for what community mental health looks like now, but we're also changing it. So I think one of my wishes is for our field to have a better partnership with the universities and the colleges that are sending us all of their great graduates from their MSW and their social work programs to have a better understanding of what the work actually looks like in practice and not just in theory, because there's such a big divide between those two things that I believe in a lot of ways that not having that firm understanding of what community health looks like, it contributes to our high turnover rates because, our clinicians don't expect to come in and have a caseload of, 80 or 90 or 100 clients, and then, they're learning the job, there's some burnout, there's some frustration with what's going on because it's not matching up with their vision of being an outpatient counselor in more of a private setting than what kind of our reality is.
Have you looked at what percentage of behavioral health providers are actually providing care in the community? We found in dental that when we went from 5% of dentists practicing in public health or community settings up to 15 to 18% of dentists now practicing in those kind of settings, now we can go to the schools and say, look, 1 out of 5 of your graduates is going to be working in the kind of settings we're working in with very, very high need populations, high level of disease. As a result of that, we can now influence their curriculum a little bit because we're a significant percentage of their graduates. Have you looked at that as an opportunity to influence the educators?
I think I haven't been directly involved in the work in communicating with the schools, but from what I understand, the schools that we've been attempting to partner with aren't necessarily wanting to hear the feedback that we'd like to provide them with. So I still think that there's still a lot of work that can be done around developing partnerships that would mutually benefit both disciplines or fields. But that's a good point. I'll definitely go ahead and see if we can collect data and use that to help influence.
I would certainly encourage it. And the other thing we do is we certainly have undergraduate rotations through the community settings. And that really helps a lot if you can move in that direction.
So this is Tracy from SIU, and what we have really found is creating programs around things that bring those interdisciplinary groups together. We do have like the Camden Coalition that works really just with super utilizers, and there's a whole curriculum around it, and we've been able to get the School of Nursing, the School of Behavioral Health, the business school, the medical school, the nursing school, the nurse practitioner school, the PA school, and the School of Dentistry and the School of Pharmacy to all select 2 or 3 students to participate in that group activity for 6 months. And together we work with patients that have that are super utilizers, and a lot of it comes back to dental needs because they've got so much pain they're going for medicine all the time. But it's a learning, and I know that's just one example, but it hits all of their specialties, but kind of taking it around the patient has really created a great learning mechanism for our schools in the area.
Okay. All right, well, I'm going to move us along in the interest of time. Just to remind folks, the 4 components of our model that we've referred to throughout the session. We've stressed the importance, you know it, I'm sure you're sleeping and having dreams about it, the importance of governance and supporting your initiatives, the practice transformation. We heard this morning, people are creating new templates. People are looking at scheduling. What needs to change as a result? What is your care management going to be? Who's your cohort? How are you going to manage them? And today, our focus is on the health information technology and the analytics. So with that, I'd like to turn it over to Natalie.
Okay, and so for those of you who are contemplating more going beyond sort of P4P or into more either bundled or episode-based or partial risk, this is going to affect you more than it is going to affect folks who are kind of more comfortable in staying in the P4P world. And so when you make changes in the way you get paid, we've talked through these last many weeks and sessions about how it is your business needs to change to reflect what it is you're contractually now required to deliver or obligated to deliver. And Carol's right, that includes new sources of data, thinking about new sources of data. And it also includes new analytical techniques. When you work with new types of data, you've got to understand what that data is and what it isn't, how it is you're going to use it, and then particularly how it's going to support your new or changing functions. For example, you talked about needing a template to collect information that you haven't really had to grapple with before. And so if you're collecting that information, presumably you're going to do something with it, identification and stratification, care planning, something, because it's expensive to get data. And the more you can be clear about how it is you're using it to make a decision in the context of a business challenge, the more likely you are to spend those scarce resources getting the right kind of information. So this is all about the kind of data you're going to encounter, the kind of analytical techniques and technology infrastructure as you branch more into the pay for value world. And so analysis always starts with data. And one thing we've noticed, a lot of us from Optum come out of payers. More and more of us are coming out of providers. And they're really like from two different planets when it comes to data. It's been a bizarre realization to come to grips with fundamental differences, not only in the actual data itself. Claims is different from clinical. There are all kinds of clinical languages, but what it is people are trying to do with the information, why it's important. So payers are typically trying to manage a network filled with contracts. The contracts stipulate who's going to get paid what, when, how. And payers are trying to understand how much services are going to be used, what those services will cost, who's likely to use those services, and what that means in terms of revenue, and what that means in terms of expenses going forward. And that's something you as providers, if you take on more sophisticated value-based contracts, something you're going to have to come to terms with as well. And these are kind of muscles or skills that you're going to have to solve for in value-based arrangements. So what payers are trying to do in terms of underwriting is quite different from what providers are trying to do in terms of delivering care to people and improving the health of populations. And so in the world of providers, we talk about clinical information. And, on the payer side, we're naive enough to think, well, clinical information, well, we could get that from CPTs or HCPCS or ICD-10s. And that doesn't even begin to cover the world of providers in terms of their data. LOINC codes, SNOMED, all of this stuff, NDC, National Drug Codes, National Uniform Billing Codes, e-prescribing standards, HL7, version 2, version 3, X12. So the types of data and how data is shared and transmitted in providers, I think, is in some ways vastly more complex than for payers. But, that's coming from the payer environment where, we think we've got this claims thing licked. And we have often also found that as providers get into the payer roles, and my colleague Sherry Onley calls them payviders, they tend to assume that claims are easy, and then there's a struggle with claims as folks in the provider side learn that new language. The ideal set is really a blend of both. And it's not just, the many clinical languages put together with the many types of payer languages, but it's also the need for really current and timely information. If you're going to make decisions about treatment, so for example, dentists, you have a passion for helping women who are pregnant get all the dental care they need, and their subsequent babies getting the dental care they need through a certain age, because that improves physical health as well. You need to know that a woman is pregnant, and the earlier you know that, the more you can begin to do what you need to do. You'd like for the information to be complete. For example, dentists, in your work with women who are pregnant, I'm sure you'd like to know which have gestational diabetes and which don't. And patients are not always the best source of information about some of the conditions that they live with. We'd all like to find out, for example, if people who have a chronic physical condition have comorbid mental health conditions, because unless we treat the mental health issues, it's pretty hard to get them to do what we need them to do in terms of managing their physical conditions. So comprehensive is really important. A one-stop shop for information would be great. And we've also learned that unless, especially in the clinical setting, unless you make information really accessible within the existing workflow, like available within the existing EMR, it's very hard for people to stop what they're doing in their normal workflow, go somewhere else to look something up, and then flip back into whatever they were using before. People tend to prefer having information where they expect it, when they expect it, in the format they're used to looking at. So that's cultural change as well. And then ideally that information could be extracted and configured in ways that satisfy multiple business objectives. How's the quality? Is our prenatal dental care reducing emergency department visits and inpatient stays, especially for women who have comorbid physical conditions? So, is our program working? So lots and lots of demands and expectations from data, and really as entities, whether it's payers who are starting to get into the provider business or providers getting into the payer business, really struggle with their new data frontiers and what to do about it. So, okay, where is HIT headed? And what are the implications for providers like you who are contemplating getting into value-based relationships? I would say, while technology has definitely evolved, analytical technology, the capability to deal with the sophistication of healthcare data has evolved, we've still got quite a long ways to go. We have HIEs, for example, health information exchanges. And the promise of HIEs was that we would have the pipes to exchange all kinds of neat information about our shared patients. And while the pipes have been easy to build, I don't know that as an industry we've thought enough about, well, okay, what comes out of those pipes and how do we normalize it, especially with all these different types of data languages, these different instantiations of EMRs, these different claims infrastructures. They may use the same code terminology, but every single system has some of its own proprietary stuff. And what does it mean to actually reconcile all of that into something that's meaningful about our patients? And so HIE is certainly providing pipes. It's unclear if there's a lot of value to what's actually flowing through the pipes. Market strides through meaningful use and other policy evolutions and the adoptions of electronic medical records or electronic health records. And from our perspective, what we've heard and experienced is that safety net providers in particular have done an outstanding job of adopting EMRs and other health information technology. But at the end of the day, an EMR was designed to in essence, run a clinical operation. Just like a claims system was designed to help a payer run their operations, neither of those two pieces of infrastructure, as ubiquitous as they've become, are really there to take care of patients. That's a controversial statement. Does anyone want to push back on that one? No? So I think we sort of try and bludgeon both of those types of infrastructure to produce something useful in terms of patient insights. And a lot of the emphasis then in that sort of fourth tranche of technology called analytics is around the creation of registries and reports. How are we doing having our patients who live with diabetes have their hemoglobin A1C checked? So there's a proliferation of measurement schemas. We're standardizing around HEDIS. In Medicaid, we've got the CHIPRA measures. We've got the adult core. There's NQF. There's ARC. And lots of vendors, including Optum, of proprietary health analytics technologies. And still, we've got that last piece of really reconciling, truly harmonizing disparate data, and then structuring it in ways that are useful for decision-making wherever it is that somebody in the whole ecosystem is trying to make a decision and figure out what to do next. And our contention is that reporting is wonderful. Registries are good starts, but how do we get closer and embedded into point of decision-making, and how many points of decision-making can we influence with useful information that makes the clinician's job easier? So that's the challenge for health information technology. And in some ways, I things like meaningful use might actually be driving us in a direction that may not be as helpful as we hope. The first meaningful use 1 and 2, there are always jokes about meaningless use and frustration among the provider community. But I think there are some more serious challenges to some of those policy directions. For example, the requirement around having a patient portal as part of meaningful use certification. So if I'm a complex patient and I go to Dennis's organization to get my teeth worked on, and I have diabetes, and so I go to Tracy's organization for my primary care, and then I go to Renee's organization for my mental health because I also live with schizophrenia. Who has my information, and are they all talking to each other? And is anyone listening if they are talking to each other? So I'm not yet convinced that meaningful use is going to be terribly impactful as it stands in really helping patients achieve better outcomes. But that's no reason to take our foot off the gas pedal with regard to evolving health information technology. So in an ideal world, we would have infrastructure that connects as many data sources as we possibly can join to. And you could argue, well, an HIE does that. Yes, it's necessary, but it's not sufficient. Because that second step we think is critical, and that's the understanding of the data by harmonizing it and organizing it into really a shared longitudinal patient-centered record. Unless it's properly harmonized, unless data is truly harmonized, we're not quite sure how it can produce valid analytics. And then our belief is that, and we've seen this in practice, the more information you can get together from the greatest number of sources to create the most comprehensive picture of each patient in the population, the more you can work with rules that automate what I think we're all trying to do in terms of care coordination. However we define that in clinical management, however we define that. Think about payers and how many times you've sat on the phone with payers, you or your teams, to ask for prior authorization for something. And they've said, well, what clinical findings we're going to ask you for clinical findings to authorize that payment for services or to authorize those services in the first place. And so then things get stopped. There's a transfer of some clinical related information in a conversation or a fax or an email or something, and then carry on with the next step. And if payers had access to clinical information, and if providers had access to claims information, our argument is that you could automate a lot more of what both are trying to do. Well, then you get into the problems of multi-payer and security, but we think there are ways of resolving that too. And we think all of this is really necessary if you're going to actually engage stakeholders, not least of which is the patient, and by the way, it's their data. So strong feelings about the right infrastructure and what really is successful infrastructure when it comes to meeting the goals of value-based contracts. Questions, comments? Okay. So from our perspective, another learning that we've had, and maybe in some situations it was a hard lesson, was that as excited as we all get about technology and convinced that if we get ever more data, it's going to solve our problems. It's very easy to think, and I think the vendor community might be partially responsible for this, the technology is a silver bullet. It very seldom is. But one of the things we learned the hard way is that there needs to be a meaningful clinical model first. And that clinical model is essential to pointing the way to what it is we need out of data. So what are the things in your clinical model that you're actually trying to do? Dennis, in your case, you're trying to get women who are pregnant to come in. You're trying to get women with small children to come in for preventive care, and you're trying to educate them about the importance of dental health, and you're probably trying to get them to see as many other providers as they need to work on their key health concerns, whatever those might be. So, you know, all true?
All true.
So, you know, my guess is your clinicians have learned to talk about things other than strictly brushing and flossing. Your clinical model would demand that they talk about other things.
Very true. Yeah.
And so, do you want to talk about what you think your clinical model is?
My clinical model?
Yeah.
For providing care to pregnant women?
Yes.
Basically, number one, convincing the dentist to do it. They have hang-ups about the safety during pregnancy, so you have to overcome that. The next thing you have to look at is you have to educate around use of x-rays, so you're not over irradiating, and maybe things like shorter scheduled appointment times later in the pregnancy because they're not real comfortable flat on their back for long periods of time, as probably most of you on the phone know. So things like that, some basic things. But the biggest thing is you just have to really convince them to provide all facets of general dentistry during the pregnancy. And then we have to block time to make sure that we always have adequate time to treat the pregnant women because it's such a high priority for this organization. Are those the kind of things you were seeking?
Yes. You know, that says that Dennis and his organization have a clinical model. The clinical model influences how they schedule appointments, who they pick to participate in that in terms of dentists. Dentists have to be convinced that it's okay to work with moms who are expecting. And then there are clinical pathways, for example, how you do and don't use x-rays. And my guess is there are probably educational components for the women themselves and convincing them to bring their kids in if they have kids. And my guess is you've got referral patterns that you bake in or anticipate as reasonably standard, given that these are women who need prenatal medical care as well.
Very much so. I mean, to the point where even when the dentists are taking a health history, we're now to the point where the dentist may ask a question of a woman, are you thinking of getting pregnant? Or are you planning on getting pregnant? And that would open up a whole different set of questions and referrals if that answer is yes or maybe not, or depending upon the vagueness or the certainty, then that will even lead different kind of questions for motivational interviewing based on the answer. So it's really important part of our DNA, and it was very, very difficult to change that DNA back to an earlier conversation.
Okay. And my guess is that you've also changed the information you collect and how you use that information to make decisions about the program and about specific patients. For example, are you contemplating becoming pregnant?
Absolutely. Even on the super bill, we'll have dummy codes to track the woman during her pregnancy.
Right. Right. And in this case, you know, this is a pretty simple clinical model that was geared more towards kind of primary care. You know, there's the perspective that, you know, look, in primary care, so I apologize for those of you who are not directly in FQHC, but I'm hoping that there's an equivalent in your world like there is, you know, there seems to be in yours, Dennis, which is dental. And that is, you know, we're working with a particular cohort or population. What is it specifically that we want to have happen and why? And then what information do we need to understand when that needs to happen and what comes next? So, for example, if I'm going to work with people who have been to the ED a lot the literature would say, okay, the first 24 to 48 hours are kind of the teachable moment. You sat in the ED for a while, maybe it was crowded, you didn't get seen right away, it took a while to get there, and, maybe the value of the advice, clinically I'm sure it was relevant, but, was that really the right setting? Could there have been a more productive setting where if you had some other needs, those could have gotten met as well? And so, as you're kind of thinking about your experience in the ED, 24 to 48 hours is that sort of teachable moment. But if you're going to, from a clinic standpoint, educate patients who are recently in the ED so that they better understand that, hey, you're there for them, you want a relationship, here's when you're open, here's how would love to see you, when can you come in? If you're going to take advantage of that teachable moment, there's a lot of information that you need. Which ED, when did you go? What happened in the ED? What were the instructions when you left the ED? And what do you need next? And so information technology is critical in structuring, structuring what it is you need to understand in order to execute that I would say it's a workflow or process around following up with people who are in the ED for non-emergency visits. Does that make sense to folks?
Yes.
Yes.
Implications for timeliness, what kind of data, and it's sort of tempting to say, well, we'll take any information. Well, is claims information that's 4 months old going to help you take advantage of that teachable moment? Well, no, probably not. Does it mean that you would ignore claims information about an ED visit? No, hopefully not. But in terms of really supporting your clinical model, what would be better is admit, discharge, transfer data from a hospital, either directly or through health information exchange if the one in your area is providing that data. So think carefully about the clinical model and tailor the information you need to help you execute on and understand the efficacy of that clinical model. So that said, claims are useful, and so as you start to work more closely with payers, insist on getting claims information. Get it as timely as you can, and if your payers with whom you strike value-based contracts are willing to conduct analysis for you, see if you can jointly conduct that analysis together versus just sort of passively receiving it. Invariably, we find that when claims data starts to flow, there's a huge amount of interest. And, people want to dig. Oh, okay, well, with that FQHC number 4 there, oh my gosh, they had ED rates per thousand of, astronomical, almost 2,000 per thousand. That means, people are going to the ED twice in a certain period of time. That's crazy. What happened? Who are those patients? And why are they going to the ED? And those are all good questions to ask. And when you first start to get this kind of analysis, your clinicians and your leaders and others will ask a lot of those questions. Those are great. And at some point, though, you have to get beyond sort of the oohs and ahs of what's happening with the population when they're, and claims will tell you what's happening with them when they're not sitting in front of you within your 4 walls, which is what your EMR tells you. That is what happens within your 4 walls. Now you need the other view of what happens when they're not there. But at some point, you kind of have to get over that, and you have to start to really understand from claims or other information what it is actual patients might need. And so you get beyond panels into specific patients. What sort of demographic information is there about them? Where do they live? How do we find them? What kinds of admissions have they had and for what sorts of problems? What sorts of conditions do they have? and what sorts of care do they need given those conditions. And then if you can, what are risk scores is sort of easier ways of using pre-canned analytics to help you get a first cut at who your highest risk patients might be. If you're going to use risk score technology, make sure you understand the difference between retrospective risks that are typically used to calculate future utilization and related costs, versus prospective risk scores. And there are lots of different types of prospective risk scores. For example, you can have risk scores that tell you the likelihood of an ED visit within the next 12 months, or the likelihood of a behavioral health inpatient stay within the next 6 months. So, ask a lot of questions about your risk scores, if those are provided to you. Be willing to roll up your sleeves or have somebody on your team do a little research to look into the way the risk score is calculated. There are lots of products out there. There's the Hopkins Grouper, ACGs. We offer ETGs. Verisk has its own. Many companies have risk analytics technology. Ask the hard questions. Understand how they work and what they're actually calculating, especially retrospective versus prospective. And then there's some things that you want to start to contemplate as you take on more risk, like in terms of bundles or gain sharing or two-sided or even subcap, and that is system leakage. If you have a network of providers, whether they're all in your clinic or you're Dennis Lewis Dental and you're collaborating with these two FQHCs in this community mental health and your network, what is it that's happening outside of your collective walls that you need to understand, and why is it happening, and what are you going to do about it? Ultimately needs to become part of your clinical model, but this is information you can get from claims. Okay, so we've also worked with a lot of payers who say, oh, right, you want claims. Well, here you go. Here's this nice Excel file. These are all the claims from one individual. Here you go. Have a good day. And has anyone seen anything like this? You've asked for kind of clinical insights or claims or utilization information from a payer, and a nice Excel file shows up that looks kind of like this?
Yes.
Yes.
Yeah.
Okay, so what did you do with it?
Oh, I spend a lot of time and try to make sense of it and pull things out and make charts, and it takes a while.
So was that a payer that was willing to work with you on the structure of the reporting, or how did it come to be that you were in possession of that lovely file?
Yeah, so this is actually stuff I typically get from our IT department. So I can get stuff from them, and it kind of comes to me like that, and then I kind of make sense of it. So I think it's based on, it's often based on claims that we've filed and things like that. That's the easiest stuff for me to get. Or I'll get stuff that's like, I'll want to know everyone. I can give them parameters. I'll want to know, for last fiscal year, patients who had 2 hospitalizations and also have a specific primary diagnosis, and they can give me all that, and then I'll just kind of do something with it.
Okay. Do you try and make the charts like this, which patients went where for what, and for what reasons, and
yes, or where they came from, or that, depending on what it is specifically that I was asked for that I'm interested in, I'll just dig a little bit deeper.
Okay. So, just a thought as you structure your contracts with payers. think about how clearly you can specify the information you need to operate your clinical model and the timeliness, the transmission of that information, and consider embedding that in your contract with also the ability to audit. Because when payers make calculations, for example, potentially avoidable admissions here, there are lots of definitions about what's there's potentially preventable visits. There's ambulatory care sensitive conditions. So think about the terms, the analysis that you're really trying to do, and negotiate with your payer and try and get it in contract. How it is you want data structured. If you're not going to take on the role of slicing and dicing and playing with that data and figuring out how to inject it into your operations in various ways, and make sure you reserve audit rights and capabilities for yourself as the provider. Okay, so this would be much better. This actually is what the state of Minnesota gives our 10 FQHCs. We also get some other reports, but we found that they're kind of like the ooh and ah factor is really high when we first got them, because it told us, okay, this patient has this type of condition or these types of conditions, and here's how many times they've been hospitalized, and here's how many times they've gone to the ED. But it didn't always get us all the conditions in which we were interested in. It was kind of limited to the big five. None of them were mental health. And we actually, per our clinical model, really wanted to know why somebody was in the hospital and which hospital. So it was great that we knew somebody had been in the hospital 6 times in the last 12 months, but we really wanted to understand why. And we wanted to understand what other care they had received. So the state of Minnesota, we said to them, let's just give us the raw claims, please. You can take out the paid amounts because those are proprietary. And we'll take it from all 6 Medicaid payers, and we'll mash it up, and we'll do our own thing. And so, we came up with this as a view for, and I'm sorry, you'll be able to see it better when you actually get this presentation. And if you ever want a demo or more in-depth discussion, let us know. We'd be happy to facilitate that. But we actually wanted something that was a meaningful patient record, because we had clinical information that we wanted to integrate with our claims information. And we wanted it sorted in a way that a busy clinician could easily see what's going on. And so we did a fair amount of work with the user interface here. For example, all of these are little portlets here, like health conditions. They wanted to know what health conditions any individual sitting in front of them had. They wanted to know visit history. They wanted to know allergies, but they quickly wanted to know if no allergies were found, don't launch that portlet. So use my eye space here judiciously. So we had a lot of design sessions with our clinicians, and this is what we came up with. And this is just a claims view. And this is something we worked hard to make available within the care setting, meaning single sign-on with the EMR. And there were lots of clinics that weren't ready for that, up for that, so some clinics just didn't integrate. That's okay. The other lesson learned is, there's a certain kind of level of maturity or readiness to take and deal with new data. That takes some thought and careful preparation. So even more better is when clinical and claims get integrated. And this is when you start to get your clinicians integrated. You're displaying information that helps them because it's more akin to what they're used to seeing, and it's not just months-old claims information. And there are also ways of sorting information so that you are doing your best to draw the eye to what needs attention. Lots of things you could pay attention to and could take an interest in, usually only a few things that you should. For example, if someone has diabetes and they're managing their hemoglobin A1C very well, and they have new test results that come back, and those test results were in normal range, great. Move on to something that's out of standard. So think about, as you work with your IT staff and what your business users need, that principle of managing by exception as you present data, so that it's just not a raw report of things you know already happened and expected to happen, but things that you actively need to pay attention to because they didn't go the way you had expected them to. Does that make sense to folks?
Mm-hmm.
Yes.
Okay, so a lot of what we've been talking about so far relates to many of the risk type arrangements we have discussed. When you get into full risk or delegated, subcapitation or whatever you call it in your part of the country, and that is, you're responsible for all the care and all the expenses of a cohort of patients, then we're talking about full risk, because if you don't get it right, you could actually lose a lot of money. And we know a lot of safety net providers are not yet there, and there are some constraints about the use of grant dollars in risk-based arrangements. So we don't expect that anyone's fully into full-bore capitated risk for all services. And we urge you to think carefully about what information technology you really need when you get into that level of risk, and what that connotes for your operations and for the team that you need to do the work. So if you're going to take full-borne risk, I think we call this the placemat slide. And here are the things that health plans need, because they are payers and they do have full financial risk. Here are the capabilities they need, and all of these capabilities have implications for technology. So this gets you into a realm of technology when you've got that degree of risk that may or may not be desirable for you. Is anyone contemplating full-bore risk, financial risk?
Hi, this is Renee. We've been talking about taking on full risk for a couple of years, and I believe a few years ago we even put together a proposal for one of our local coordinated care organizations, and I don't think that they were quite ready to move ahead with that yet, but we're revisiting that conversation right now. We've been doing capitated payment for a few years, and it just seems like, we kind of need to take things to the next level in order to start moving the dial on health outcomes and decrease utilization and stuff like that.
Okay. So then my guess is these are some of the considerations you had, who pays the claims?
Correct.
How do you set up medical necessity reviews? What does it mean to reconcile the payments to the premium payments to the medical and other service expenses that you have?
Yeah, and I think really, in order, it seems that I think that if we want to, it's a good, we need the money, right? Without having access to some of that full money, the money that comes with picking up people's full risk it's very challenging in community mental health to have, the money that you need for the services that you want to provide to move the dial. So I think really we're viewing this as an opportunity to, really improve the wraparound services and support, and to have a financial model that sustains the clinical model that we want to provide to get the outcomes that we want to achieve.
And you may want, even with sort of less comprehensive value-based contracts, you may find you need some of these capabilities and related HIT infrastructure. Dennis, if you got into the business of taking gain-sharing risk for women who are pregnant, you may wish to have some of the specialties on contract that you find, for conditions you find are common in women with pregnancy. You may wish to have special arrangements with some of the social service providers that influence health and well-being for women who are pregnant and insured by Medicaid.
True.
You may want to get into this business of standing up and managing a network, otherwise known as a system of care. And you're right, Renee. It's sort of like everybody's interested in some cap or cap-based risk because that's the only way you get the dollars. On the other hand, it comes with a whole lot of additional responsibility and health information infrastructure and related people that you may not be ready for. So, whoops, skip ahead. Lessons learned here. I think we've talked about some of them, so we'll just go through this reasonably quickly. Most of you are providers, so that means you may have a fair amount of earned disdain for claims, but they're important. They tell you things about your patients that you may not know, indeed. And so we encourage you to try and see the glass as half full and do what you can to find value in claims. Analytics are expensive. Nobody on this call has unlimited resources. So the clearer you can be about what it is you're trying to achieve and how you're going to achieve it, the more precise you can be about the analytics, the more judicious you can be about the analytic investments you make to get you the data you need. Get started, though. I have huge admiration for the person on the phone that took that ugly claims file and tried to make silk purse there. Don't let perfect be the enemy of good enough. Just get started and use the experience to understand what it is you're going to need on your team more broadly to deal with new types of information. Keep data and analytics in context. I think we talked about this. What is it you're really trying to accomplish? How is this information specifically going to tell you whether or not you are on track? And it's not just about you managing a contract. It's also about all the things that have to happen in your practice to support a wide range of people trying to get their work done too. And change is really hard, as we've talked about. Be prepared to tell your story over and over and over again. Make sure your leadership team is in lockstep. And that extends to making the kinds of investments in health information technology that you will need ultimately to be successful in value-based relationships. And that's also not just the technology, but the people to get the best out of the technology. So be prepared to spend some money to get the expertise you need to really optimize other investments in the bits and bytes of data and related technologies. We would also say consider shared purchasing or joint purchasing. This technology, these types of technologies aren't cheap. If you can come to agreements with other participants in your system of care or collaborators that need similar types of information from similar sources, what can you do together? Whether you're part of a health center controlled network or another type of consortium, think about how you can leverage your scarce dollars collectively. Okay, Carol, turn it back to you.
I'd like to open it up. Any questions for Natalie? Any comments based on your organization and where you're at? I'll say something. Dennis mentioned something that I don't know if it got heard. It was sort of an aha moment for me. Dennis, you talked about entering what you call them, rogue codes, because your system didn't capture the codes that you needed. So you came up with codes?
Yeah,
okay,
we create them. We just call them dummy codes. So dental codes are 5 digits long. So we just play with usually letters that would indicate things that we want to know. For example, we may want to know if somebody's coming back for their recall check, their regular checkup, are they disease-free at that checkup? So we created a code, DFA periodic PE, which just means to us is decay-free at periodic exam. For you and I, going to the dentist and having a clean checkup is hopefully what we're all after. But in a high-risk population, that's a rarity, and it's worth celebrating when we actually get there. So we just made a dummy code to track it. And we do that with a lot of things. Yeah, we just create dummy codes that we can very easily run a query for in our software program, and it will pull up how many of those we had by date, by age, whatever query we want to send.
I just thought that was brilliant. You know, depending who your partners are, if you're going to start transmitting data to a payer, that's going to freak them out that they don't know the code. But you know, don't let your technology tell you how to do your work. You know, build your system to support your work. And then I don't know who mentioned it, but somebody said on the call that you what I heard is you tried to present a value-based contracting opportunity to was it a community, a care coordination entity, and they weren't ready for it?
Yeah, that was Renee.
Oh, I that just hit a spot in my heart. I remember working for starting a huge, you're familiar with the dual population, a huge government initiative in Illinois, and I was working with a very large payer in the state, and you know, we were so busy getting our contracts set up, our providers set up, blah, 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 and reviews. And I had a marvelous community partner say to me, hey, Carol, as we enter into this relationship, why don't we do this value-based contract? And I was like, oh, my God, I'm not ready for this. Because we just, and I thought I was the payer, and I should have been ready for that. But I tell you, the light bulb went on in my head that I thought this was really a value partner for me. That this was somebody who was looking at innovation, was looking at a new way of doing things, and was willing to go at risk for me, that she felt really good about the care that her team was providing. And we talked to her about it a year later. So just don't give up the hope. All right, please. Someone was going to say something?
Oh, I was just, this is Renee, I was just going to say, yeah, I mean, I kind of feel like there's so many fantastic, wonderful opportunities in healthcare right now, and you know, it just there's a lot of competing priorities, and I certainly don't think it's because any of our partners don't value the idea of doing taking on the full care or the full risk for someone, but there's just a lot going on right now, and to figure out how to do that in a way that works for, both partners as well as for the larger system, and at the same time being ready to have those conversations with a number of providers across a very large system. I can completely understand why they weren't ready at that time, but I think we're kind of getting to the point where we can revisit that conversation, and I think everyone's a little bit better prepared for that.
And we talked about on one of these sessions, have patience, which is hard to do. I'd like to recognize on the call Dennis, our Don Quixote of the group. Dennis, how long have you been singing the dental song to your community? Over 10 years about, if you give quality care to pregnant women and what only they're...
Yeah, it started about a decade ago. Mm-hmm.
So it can get discouraging being the lone wolf out there, but remember Don Quixote. All right, any other comments before we move into your homework for the last session? Okay. Would someone mind moving the slide for me? For some reason, mine is not moving forward. There we go. Thank you. Okay, so we meet again. We're back to our Tuesday session, so our final session will be Tuesday, August 23rd, same time. But this time, the content will be your content. And what we'd like you to do is to create, we want to limit, to keep everybody focused and on time, create a seven slide presentation, PowerPoint, or whatever you want to do. and be prepared to talk about 10 minutes. What I think what we've really liked over these sessions is how we've gone from presenting didactic information, which keeps us on the same page and we're all speaking from the same hymnal. But I think what the whole learning collaborative about is the sharing of information and experiences, wins and frustrations. So, keep it to 7 slides, about 10 minutes. If you go a little under, a little over, we're not going to sweat it. First slide, just, do an overview of your org, what type of org it is, population you serve. Then we get into think about each session we've had. Describe the contract that you currently have in place, are considering, or anticipate. Some people, have got it going and they know that it's coming with their RCOs. Don Quixote out there is, hopefully 15 years from now, if not sooner, he'll have something. So what would you like that contract to be? Maybe go back, look at session 1, look at that value-based contracting we proposed. Maybe come up with your own. What are you going to knock on the door of providers or payers? What would that contract look like? So describe it, who the payer is, what the payment structure is, and time frame. Again, if you've got it in place, great. Tell it to us. It'll help us be more helpful to you. If you don't, you don't know, it's an unknown, or give your best guesstimate. Talk about, on slide 3, your governance structure. Who is going to help you lead your program, lead the structure you need for it, and how are they going to support this contract and implementation? Describe your particular high-risk cohort. I think each of you now have had a chance to do that, but just review what it is, whether it's the ERs or the diabetics, the dental, pregnant women, whatever. And what 3 interventions did you identify for the cohort? And for each of those interventions, can you help us understand how you came up with that intervention? Is it based on an evidence-based guideline? Is it based on a contract deliverable? Where did you come up with it? We don't want you to shoot in the dark. Where did you come up with that? And is it currently in place, or will you need to get it started? And 6 slides, given your cohort, given your interventions, what changes do you need to make in your processes or practice in order to make those changes? And 7 slides, sort of a rehash of what we reviewed today. In terms of technology, what reports or data sources are you going to need to measure your results, your impact, whether you have it in place and you're going to be able to run that report, or, oh my goodness, you don't have it because you don't have dental codes and you got to make up something to then be able to run the report. What are you going to need? So again, 10 minutes, 7 slides, keep it simple. You all know my email. This is Carol. If you run into problems before, it's carol.dahl, D-A-L-L, at optum.com. To help AJ out, if you could email the PowerPoint to him Friday, he will then load it onto the platform, so we will be able to use it. AJ, are they going to be able to move the slides? Did we work that out, or we'll have to move it for them? How did that work out?
We'll be able to figure it out. Either way works.
Okay.
So.
Okay, we're good. All right, guys. Susie, Tracy, Renee, Dennis, does this make sense? Any questions? How are we tying it all together?
Yeah, it looks good.
Well, so here's some little hints. If you have packaged up what you're trying to do. So, for example, we have a client in Illinois, another one that has an ED diversion program that is, getting some pretty compelling results. And so the work we're doing is essentially helping them package it up like this. So think about this as the beginnings of an artifact that you could take to a payer and say, hey, here's what I want to do. If that helps you. If that doesn't help you, I apologize. But
Natalie, that makes great sense. As long as you're doing this exercise, have it be useful for you folks. That's great. Okay, don't hang up. Just a reminder, your feedback is important to us. AJ, as always, in the top box there over to the right, there's the Survey Monkey. We look at that feedback. Hopefully we've made some changes based on your suggestions. We love the good, but we always take action on the suggestions for improvement, so they're very much appreciated. Okay, anything from the Optum team?
Nope.
AJ, anything from your end?
Nope, I think we're good.
Okay, have fun putting your presentation together for your future payers. You'll run it by us. If you have any questions, please email it to me before. We'd love to give you help, and we'll see everybody back Tuesday, August 23rd, same time. Bye-bye now.
Bye.
Bye.